Welcome to this high-level panel event, which launches our International HPV Awareness Day commemoration, which will get into full flow tomorrow on March 4th. HPV Awareness Day was initiated by the International Papillomavirus Society as part of our commitment to end the harm caused by HPV. The campaign is unique in its focus on the virus, which is not widely understood and still carries harmful stigma for many around the world. This event is one of a range of public awareness and educational activities coordinated by IPVS and delivered in collaboration with our network of around 130 partners around the world. Our panel today brings together a broad cross-section of experience and expertise to share perspectives and explore potential strategies for improving the effectiveness of screening as a tool to eliminate HPV-related cancer. I'm delighted to hand over to our panel, moderator Tamika Felder, whose experience as a broadcaster, cervical cancer survivor, and NGO founder will, I'm sure, support a lively and insightful discussion. Tamika, please.
Thank you so very much. I'm so honored to be here to moderate this discussion and help kick off such a wonderful day where we all come together to spread awareness around HPV prevention. I'm also happy to introduce this wonderful panel, and we'll have each of the panelists introduce themselves and share just briefly about the work that they do, and then we'll get into this discussion and we ask you, those who are watching and joining us, to just give your thoughts within the chat, and we'll be going to those questions if we have time, and we appreciate your input as well. So we'll start with Her Excellency, Dr. Bagadoo. If you will briefly introduce yourself, and thank you so much for joining us. You're muted.
Hello, everyone. Hello, Tamika. Thank you. My name is Dr. Zainab Bagudu, Shinkafi Bagudu. I'm a pediatrician, first of all, and then I ventured into cancer advocacy, lead an NGO, a civil society known as the Medicaid Cancer Foundation. I'm also the First Lady of Kebbi State in Nigeria, a board member at the Union for International Cancer Control, and do most of my work in cancer policy advocacy and working at the grassroots to increase awareness, particularly in my state in Nigeria. It's a pleasure to be here.
We're so happy to have you here. Millicent, please introduce yourself.
Thank you so much, Tamika. Hello, everyone. I'm Millicent Kagonga from Kenya. I'm a cervical cancer survivor. I'm the HPV vaccine ambassador in Kenya, my daughter being the first one to be vaccinated. I'm also the face of cervical cancer elimination, the face of from WHO. I'm the one on the page of cervical cancer elimination. Thank you. I'm so humbled to be here.
Thank you so much. We're happy to have you here. Dr. Coulson.
Hello, how are you all? I am Dr. Mosammed Umme Kulsum from Bangladesh. I'm working on cervical cancer project in Bangladesh, in one of the project as a project coordinator in an NGO. We are providing service directly to the root level in both the north and south part of Bangladesh. And we are now working with self-swab collection. Thank you to all and making me part of this group. Thank you, and it's been a pleasure to be here.
So happy to have you join us. Lillian.
You're mute, Lillian.
That's the word of the year, right? Thank you, everyone, for having me here. I'm very excited. My name is Lillian Krapel, and I am an HPV anal cancer survivor, just reached 5 years. 3 years ago, we started an organization called HPV Cancers Alliance to create education and awareness about this awful virus and the cancers that it causes. And just an FYI, I just came back from Australia, and they're top, in the vaccination rate, but everyone I spoke to had no idea about the other cancers other than cervical.
Well, thank you so much. We're looking forward to hearing more about you, your work, and your thoughts within this space. Dr. Anil?
Hi, Anil Chaturvedi. I'm an epidemiologist at the U.S. National Cancer Institute. My research program at the NCI addresses the etiology, natural history, prevention, and screening of head and neck cancers, including HPV-associated head and neck cancers, as well as of lung cancers. It's a pleasure to be here.
Thank you so much. Looking so forward to having you here with us. I do have to say that you may have noticed that Professor Lynette Denny is not with us. She is not feeling well today, and she sends so much love to each and every one of you here. We wish Professor Denny well. We know that she is very passionate about this work that she does in Cape Town, South Africa, and if it were up to here, she would have powered through to have been here with us, but we all truly believe that self-care is not only the best way to take care of ourselves, but also so that we can continue this great work. So will you all join us in wishing Professor Lynette Denny well? And so with that, we are going to jump right into this discussion. So why are we here today? We're here to talk about not only this International Awareness Day that we have, but the work that we do beyond it, all the work that has been done. As a long-term cervical cancer survivor, when I first found out about cervical cancer and its link to HPV, being a broadcast journalist, I never remembered people really talking about cervical cancer in the general public in 2000 when I was diagnosed. And so I love that we're spreading so much awareness. And so I want to really talk to Dr. Colson and Her Excellency about really where are we today in terms of screening for cervical cancer. I know that there's so much advancement that has been done, and now we're talking about the other HPV-related cancer, but where are we today? Where are we in terms of screening of cervical cancer? Dr. Colson?
Sorry, could you repeat the question? There was disturbance in net. I couldn't hear.
Yes, where are we in terms of screening for cervical cancer? We know with the pandemic, especially here in the United States, people were delayed. We're seeing numbers coming up. There's some people who think, we have the tools that we have for cervical cancer. Let's focus on the other HPV-related cancers. But we know globally, cervical cancer is an issue. Lillian touched upon what's happening in Australia. But when we look at cervical cancer as a global impact that's happening, where are we and what needs to happen?
Yes, cervical cancer, like in Bangladesh spec, if I say, it's the second most cancer that is taking place now, with 8,000 every time new cases in a year and around 6,000 dying. Where we are working here, we are seeing that there is a government is working, but they're doing in medical college, district hospital. They're trying to even cover the root level, but unfortunately, it's really tough to work in remote areas, in hard to reach areas. So through our program, through cervical cancer, that is now globally one of the important cancer that can be prevented. So in Bangladesh, government and the NGO sectors are trying to save those women this cancer that can be preventable. And it is preventable through, we know if screening is done on time. In Bangladesh, like not all the women goes to the institute for doing screening. And in remote areas, not all the women are really looking forward to do the screening. So from my view, I still say we need to work more hard. We need to increase the coverage. We need to do more screening. We need to promote it more. This is a preventable cancer. It can be prevented, and we need to work more hard to cover this. Thank you.
For me as a patient advocate, hearing that over and over and over again, that it's preventable, but yet we constantly see those dying from cervical cancer. Your Excellency, Dr. Bagherty, we've heard from you before about what is happening in your country. Tell us what you're seeing right now and what needs to be done. And I do know you have a lot of thoughts and passion behind this. You're muted.
Hi again, everyone. Indeed, there's been a lot of movement particularly around cervical cancer, since the WHO global strategy was launched in 2020. We've seen the screening rates. Your first question was actually about where we are. And for us to talk about cervical cancer, we must talk about the human papillomavirus, which is the most known positive factor of cervical cancer. It has a global prevalence of about between 11 and 24%. And of course, the 24% end is what we see in Africa. Most women, most people will get an HPV infection in their lifetime, 85%. For us in Nigeria, it's the second commonest cancer, that is cervical cancer in women. And there's no routine screening service. Over 12,000 women get cervical cancer, and over 8,000 of them end up in death. And bear in mind that these figures or this data is not the full representation of what is happening. So there has been movement. I was looking at a study in the Lancet from 2022, just last year, and the study looked at the screening rates in 2019. It was something like 19%. But as the years go by, we're now inching towards 36%. So with the launch of the cervical, with WHO Global Elimination Strategy, which states specifically there should be vaccination, screening, and early treatment, there's definitely a global increase. And we're seeing that in low and middle income countries like ours as well. The governments and the higher, or should I say the bigger civil society, the bigger foundations are working very hard. In my state, we work with CHAI, it's aid-funded projects, and we're currently screening 35,000 women. The state government was able to scale up, but it's still not enough. We're just scratching on the surface. If we look at the global targets we need to get to, we're not going to get there. We're only going to reach about 15% at the rate at which we're going now, especially if you look at the funding aspect. I know that we might touch on the funding later, or if someone else might have that question specifically, but it's a big problem. There's not enough funding going into it. There's not enough political will. But again, I repeat, we are progressing. We're not there yet. We're not at the rate we need to be for us to eliminate cervical cancer by 2030.
So much that still needs to be done, and definitely so much more funding to help us do this work. So I want to talk about, for a long time, cervical cancer has been the only HPV-related cancer with widely implemented screening programs. Is there hope for other kinds of HPV-related cancer, especially now that we're talking more about them, we're hearing more about the work that's happening behind the scenes and going on? And I will ask of Drs. Chakravarty and Palevsky if you could answer that for us.
Anil, do you want to kick it off?
Sure, Joel. So in addition to cervical cancer, research over the past 25 years or so has now recognized a distinct subset of cancers in the head and neck region that have an HPV etiology. And these cancers generally arise from the back of the throat, the oropharyngeal region, and the cancers are primarily caused by HPV-16 infection. The proportion of cancers that is caused by HPV in the oropharynx is very variable worldwide. It's as high as close to about 80 or 90% for oropharyngeal cancers that occur today in the United States. In regions where tobacco and alcohol use is quite common, that percentage tends to be on the lower end. If we look at the other head and neck regions, like cancers in the proximal part of the mouth, the oral cavity, contemporary estimates indicate that a much smaller proportion relative to the oropharynx is caused by HPV infection. So if we have characterized these cancers at an epidemiologic level, at a clinical level, and at a molecular level, when it comes to screening, I must say the state of the science is far behind what is known regarding screening for cervical cancers and for anal cancers. And I'll try to characterize the state of the science with respect to 4 critical questions that are needed for screening of HPV-associated oropharyngeal cancers. Questions pertaining to, do we know who to screen? Who do we screen? How do we undertake the screening to identify individuals either at a high risk or who have prevalent cancer? How do we clinically manage screen-positive individuals? And 4, if and how population-wide screening should be rolled out. When it comes to oropharyngeal cancers, we know who to screen. We know high-risk individuals in the population. We have a combination of promising tools in terms of molecular assays being looking for the virus in the mouth or circulating antibodies to the virus, and a combination of imaging tools such as transcervical ultrasound. Unlike other HPV-associated cancers like cervical cancer and even anal cancer, we don't as yet have an HPV-induced precancerous lesion in the oropharynx. So when I say screening for HPV-associated oropharyngeal cancers, it is explicitly with the goal of early detection and downstaging, such that individuals can receive single modality rather than multimodality therapies, so that the morbidity and hopefully mortality can be reduced. So we have some understanding regarding these first 3 questions. What we don't have as yet is actually evidence that screening and early detection can reduce morbidity and mortality. So we have a lot of the tools lined up, but we don't as yet have the scientific evidence that could justify rolling out of screening into the populations. So that is the current state of the science. There are a lot of efforts underway to try and gather that evidence. I would say, hopefully in a few years' time, we would have answered questions and we'll come up with a comprehensive strategy for screening and early detection of head and neck cancers.
Anil, if you were to identify the populations who you would first screen once those tools are validated and available, who would you pick?
So the primary risk factor would be, it's a male predominant disease. Individuals who are current smokers have a higher prevalence of HPV-16 infections. Individuals who are HIV infected have a higher prevalence of oral HPV infections. Individuals with a history of sexually transmitted infections have a higher prevalence. And tracking with the mode of transmission, individuals who have a higher number of lifetime and recent oral sex partners would be the individuals who would be screened. So we, in our group, have put together a risk stratification model for the identification of high-risk individuals in the United States population. And the model has good discrimination with area under the receiver operating curve characteristics, upwards of 90%, I would say. So we have a good handle on individuals in the population that have a high prevalence of infection being the obligate cause of these cancers. Hope that answers your question, Joel.
Mm-hmm. And if you were to predict which would be the first 1 or 2 screening tests that might be implemented, which would you imagine?
So we could target the virus in the oral cavity. So that would be PCR-based or sequencing-based assays looking for the virus. Antibodies to the HPV-16 E6 protein also have shown to be very promising in terms of the identification of high-risk individuals with very, very high estimates of specificity and very acceptable estimates of sensitivity and very high positive predictive values. So those would be the assays that I think are most promising. Circulating virus and viral particles are also promising. What's a little unclear is if it's promising only for advanced stage disease and if the performance characteristics would be similar for early stage disease, which is what we're targeting with screening.
And Joel, did you want to add, beyond your questions, did you want to add anything else to that?
No, but I think that this discussion highlights the broad range of challenges we have in preventing the spectrum of HPV-related cancers. Cervical cancer, affects only people with the cervix. Head and neck cancer, as Dr. Chaturvedi said, predominantly affects males. The cancer that we've done a lot of work on, anal cancer, sort of is squat in the middle because all people have the organ that is the potential target for HPV here, which is the anal canal. And in fact, this is a cancer that has that sees an incidence higher in women in general, in the general population compared with men, but they're both affected. And like Anil pointed out, high-risk groups for head and neck cancer, the good news here is that we know who the very highest risk groups are of anal cancer, and these are the groups that we would most want to target for a screening strategy when it's implemented. That includes people living with HIV, everybody, basically men, women, transgender people who live with HIV, regardless of the kind of risk factor for HIV. Other folks at high risk include women who've had a history of HPV-related cancer elsewhere in the genital tract, particularly the vulva, given its proximity to the anus, but also cervical cancer. And then the other very high-risk group are people who have a history of immunosuppression for reasons other than HIV. People, for instance, who may have had a solid organ transplant, like a kidney transplant, and they're given immunosuppressive medication to prevent rejection of the graft. So the rates of anal cancer are very high, comparatively speaking, in all of these groups. And so a screening strategy, if we were to do one, would probably be focused in those individuals first. But I do want to make one very important point, and I'm sure Lillian will comment on this too, is that despite the fact that I just identified the groups at highest risk, in fact, the majority of the cases of anal cancer globally are contributed by people who don't fit any of the risk groups that I just identified. So down the line, we must also figure out a way to efficiently screen these relatively lower risk individuals. But the good news here, and we do have some good news, lots of good news. We've already heard that we're making progress against cervical cancer, though it's slower than any of us would like. We've also made some progress for anal cancer. Recently, we published the results of a study called the ANCHOR study, which showed that if you identify and treat the anal cancer precursor lesion, it's very similar to the cervical lesion that we're all looking for to try and treat it before it turns into cervical cancer. If we detect that high-grade lesion in the very highest risk group of people living with HIV, and do our very best to remove those lesions, we can substantially reduce progression to anal cancer. So again, this is a bit of a contrast to what Dr. Chaturvedi was saying, because in the oropharynx, we don't have a clear precancerous lesion, and so efforts are targeted towards early detection. We would much prefer to prevent the cancers than find them early. Finding them earlier is much better than not finding them at all, of course. But the problem with treating an early cancer is that although the success rate is quite high from a mortality point of view, most people survive it, a very high proportion of people have very long-lasting side effects from the treatment, which is usually a combination of chemotherapy and radiation therapy. So based on the anchor study, which shows that we can actually successfully treat these high-grade lesions, there are efforts afoot to try and design prevention strategies in those highest risk groups, starting with people with HIV, modeled after what we do in the cervix. And these are still at very earliest stages. The Centers for Disease Control is reviewing changes in guidelines right now to see whether it wants to recommend doing this kind of screening as standard of care for all people with HIV. And the U.S. Preventive Services Task Force recently initiated a process to review the data to determine if they want to come out with anal screening guidelines too. So I particularly appreciate the opportunity to talk about this, because this is an area that I think more people need to be aware of. But also in my role as the chairman of the International HPV Awareness Day campaign, it's a reminder of one of the reasons why we choose to focus on HPV in this campaign, because it, as was mentioned, a very high proportion of us, 85% plus, get HPV. And we feel it's really important to destigmatize, because all of us who are exposed to HPV are at risk of diseases, or diseases in people who we care for. So anal cancer, I think, is a great example of an equalizer in a sense, because we see that in a broad spectrum of demographics. So more to come, I think, in the anal cancer story. We hope that the CDC will be putting out guidelines in the next few months, and we'll see what they say about routine screening. The other issues which we could talk about later, time permitting, is that we do have serious challenges in the anal arena also, namely people who are trained to do the procedures. The equivalent of cervical colposcopy is called high-resolution anoscopy, HRA, and we have a serious shortage of people who are trained how to do that. And we also need to figure out what the best way to screen is. Much work has been done on HPV testing and cytology in the cervix, or co-testing and self-sampling, and many of the same issues are being explored for to optimize anal screening.
So you just touched on some of the things that we're going to talk about next, that we're going to put out to the entire panel about ways to reduce gaps in screening. But also, you touched on it. We're having this International Day tomorrow. We're kicking it off today. But the truth is, stigma is really still a huge, huge issue. I was listening to all the issues that, we know who's at high risk for head and neck cancers. We know who's at low risk. But again, if someone's just thinking, well, I don't have this, I don't have that, or maybe I do have those issues, but I don't want to be identified, how do we, are we still truly dealing with a stigma issue? Is the stigma less burdensome than it used to be? Where do we focus these efforts, since there's so many things that need to be done? The needle is moving, but we know stigma is an issue. And I'm just going to throw that out to the entire panel. Or do we just ignore stigma, keep doing the work, keep pushing, keep getting people screened, keep getting them in? Do we focus on the cancers themselves? But we have to talk about HPV. It is so common and prevalent. But how do we do that and get the people in? A big question, open to anyone.
I think, thank you, Joel. Thank you, Tamika. I think that the more we talk about it, the more we can normalize it. I know when I got anal cancer 5 years ago, I knew I had HPV, but I knew in my 20s I had HPV, but I was just like everyone else, blindsided. Like, what am I doing with this? And I don't like this kind of the name of this cancer. But I actually embraced it, and I realized, wow, there's huge gaps about this. I need to come forward and educate. And my biggest thing was that my provider, who I've been seeing for years, had and did the digital anal rectal exam. She told me that I was fine. And I said, I'm not fine because I'm bleeding. And she said I was fine. And I went to someone else and they caught it. And when I went back to her and said, hey, this was missed, I didn't say you. She said, it's not my area. And I said, oh, I don't like that answer, but that's the answer, because, doesn't seem like there's any kind of protocol. But back to what you were saying regarding the stigma, I think that, I speak to people every single day who are getting, women most of the time are getting anal cancer, and there's a big stigma. And I just tell them, please don't tell people it's stomach cancer, as some of them have said. Please say what it is, because that's the only way we're going to get rid of this stigma. We have to get it out there and normalize it, like breast cancer, like, colon cancer. It's the only way. We have to normalize it.
The same thing happened to me, Lillian. I remember when someone thought I had ovarian cancer and I didn't even correct them. And then at some point I was like, no, we have to talk about this. Someone has to talk about this. So yes, so true.
Yeah, I mean, as I had a big party to thank all my doctors, and I had a cake in the shape of a butt, and I had toilet paper centerpieces. I didn't care. I was like, okay, this is. I was so stunned that this happened to me that I was like, oh my God, I have to do something like right now, and I have to do it big. So yeah.
And Millicent, let's hear from you also about stigma that you may deal with, the women that you work with within your foundation and the work that you're doing in Kenya. How are you moving past the stigma issue?
Wow, thank you so much. And the stigma issue, it's everywhere. It's in our communities, and in the hospitals. It's in churches. Even it gets to an extent that you are chased away from where you are living because you are smelling. And I think the right way for us to deal with the stigma is to hear from the voices of the survivors, because I believe that the voice of the patient or the survivors is very powerful, so that we can know how to deal with it. Sometimes cancer has taught us a lot of things, has taught us how to walk, how to think, or how to talk to other patients. And if we hear the voices, or when we are doing the research, if we include the survivors, it will be easier for us to deal with the stigma. And another way for us to deal with the stigma, because the same stigma is making our women not to go for screening, we also need to make sure to bridge the gap, because this stigma is making women not to go to do the screening, the cervical cancer screening, because they are thinking, what next after screening? Am I going to look like my neighbor who just died of cervical cancer, or am I going to smell like my friend who just lost the battle due to cervical cancer? So we need to bridge to make sure, yes, we have the screening. After screening, we have the diagnosis, biopsy being in leading. I don't know about the other countries, but here in Kenya, the biopsy is like, when you go to do the biopsy alone, it's like they are giving you the satanic figures. The satanic figures in another way, meaning that it is very high, it's very expensive to pay for only biopsy. So we need to bridge the gap. After the screening, we need to make sure the diagnosis is a bit cheaper or maybe free, and then after the diagnosis there is treatment. Maybe in that way we'll be able to eliminate the stigma, because the stigma, it is there, and it is in a bigger way. I went through it. I was chased from one house to another. I was chased from the community because of the smelling, because of I've just come out and say now I have cervical cancer. So we need to work on it on a bigger way, on our facilities, and everywhere we go, we need to know how to bridge the stigma and the patient and the treatment. Thank you.
I do. Yeah. For me, the stigma hurts the prevention of the cancer itself. And we have to work on that. And again, there's so many levels to the things that we're working on, and I know that it will continue, but thank you all for just your passion. I want to also go back and talk about how do we improve and reduce screening gaps with access. You know, here in the United States, you know, we have all the tools, but we also still deal with those gaps, those health disparities. Your Excellency, how are you dealing with those in your country?
Well, I think the first thing is education and, of course, awareness. They sort of go hand in hand, but the more you have people that know about it, people that are listened to talking about it, then it becomes easier. And this is where I bring in what I call champions and influencers. You find that we do have such people in our environments. They could be community gatekeepers, they could be celebrities, or people even that are survivors from the disease like yourself, or people that have made a mark in particular areas. And when they speak about these topics, then it becomes easier for particularly the local people to accept. Unfortunately, in my experience, it needs a lot of funding to bring in the influencers that need or that can't speak about such things. So whilst education is one and awareness is one, you're also talking about amplifying the message. And then it brings us back to the funding issue. If you're going to find amplifiers and people to talk about it, you need a lot of funding. And the only way we're going to get this message really clear is by putting in more funding. To get more funding into it, it needs to be on the political agenda. It needs to be in the plans of our leaders. Our leaders need to know that, yes, cervical cancer is an issue, malaria is an issue, more chairs in my classroom is an issue. But the cancers don't get spoken about so much. Now cervical cancer gets some attention, but anal oral cancers, not as much. So those messages need to be amplified more. And for us to get the right amount of all the means that we need to do it, there has to be involvement of our legislature. The only people that can appropriate the right funding are the legislators. And, I was just answering a question in the chat room, and I might as well mention it here. We've just had an election in Nigeria, and nobody was talking about things like this. It was more focused on which party and which tribe and so on. And that is not unusual in a low middle income country. So until our democracy evolves to the point where real issues are put on the table, then where we will need to struggle as we go along. Then there are costing tools that help us along in bringing the messages to the people. I was talking to a colleague recently, just this afternoon actually, on an earlier call, and she was telling me the WHO is about to release a costing tool. So that will help the lots of cancer control plans that are out there. And then, of course, just the issue of molecular assay that we were talking about now, there are programs that exist. We had a lot of intervention during COVID. There are tools, like you said, Tamika, we're always talking about the tools that exist and so on, but we are not interconnecting them. I spoke about our program in Kebbi State. We have a beautiful molecular laboratory assay in Kebbi State, but because it's a fixed program under a particular organizations and partnerships and so on, it has to go to the central lab in the state's capital, which is at least an hour by air or 8 hours by a road trip. And so this brings a lot of delays, and the women are not as keen to come out. It's not even the women I'm having a problem with now. It's the healthcare workers. When you push them to do a program that is not part of their job description, there's no incentive for them other than, yes, we're going to have less cervical cancer patients. We're going to detect it early, which as a health worker, there's a moral obligation or you feel morally obliged to do. But the delay in getting the results puts them off. and they just think, oh, what's the point? Or it's going to get lost and things like that. So if we're able, and then what do we tell the women in the villages that we've taken their samples 6 months ago and we're still struggling to get the test? I know South Africa has done much better, but for us, we're still struggling.
And so there's some themes with different countries, and I saw Dr. Colson nodding her head, and we'll go to you next, Dr. Colson. But again, political will, funding, amplifying not only the voices of survivors, I'm also hearing health workers, incentives, and making sure that we're connecting everywhere that we need to connect as well. Dr. Colson.
Yeah, whatever Dr. Zainab have said, she's absolutely right. During the COVID era, the whole nation, globally, everyone participated in vaccine, in awareness, in swab collection, everyone participated. But when we're talking about HIV, when we're talking about HPV, no, we are not having that much campaign or awareness or talk about it. Still in our society, people feel shy talking, even in literate society, still people feel shy talking about reproductive part. Women feel shy talking to their daughters. Even if the daughter is a doctor, she feels shy talking about her private part. If she has some menstruation issues, if she has any issues, she hardly wants to go to a gynecologist even, thinking about the speculum. Oh my God, a speculum will be put inside. That's a private part. I feel shy. So this should be a national level consideration. National level, political level, the government policy should concentrate on HIV, HPV. These are preventable. We should encourage people. We should teach people. We should teach young generation. We should start education from class 4, 5, when we are starting our biology, that there is a disease called STD, and young generation, teenage should know more about it, because we are at the age of when everyone is a teenage, they do not know about many things. They have lots of partners. They hang around with friends. So it should be started. It should be included in schools' education and the books, or we cannot stop this. The campaign, the news, it should be everywhere, because these are very much important, starting from young generation. Thank
Yes,
you.
we can't stop, and we need all of those things. In the Q&A, Omar Al-Zaib, and I'm so sorry if I mispronounced that, said, thank you for indicating the stigma and discrimination associated with HPV cancer, and my screen just moved while I was reading it. Here we go, because you all are doing so great with the Q&As. But I think that increasing the knowledge of healthcare providers about HPV will assist in reducing the stigma and improving care for patients in HPV infection. And also, someone asked, this is moving, let's talk about how do we develop the capacity of healthcare system links? Her Excellency touched on it just a little bit, about, what we have, a little bit of spam in the chat. If someone could grab that, please. When you have large audiences, sometimes the technology has not gotten away really quickly for us to, so Zoom and different platforms allow for that. But we want to talk about linking. Her Excellency touched on it a little bit earlier when we're not connecting certain things, but how do we develop the capacity of healthcare systems to link together so that, one, people aren't falling through the cracks, but also that we know that people are getting screened. We know that maybe there isn't much that we can't do right now if there's a 6-hour delay or a 6-month delay, but how do we connect those links so that we make sure that people aren't falling through gaps? Dr. Bagadu, do you want to take that one first?
How do we connect sorry, I'm muted. Oh, no, I'm not. How do we connect the existing gaps? I think it's a difficult one, and it's a global problem. And it's also we keep on going back to COVID and the pandemic and the response, but we will, because we did well when it came to the COVID pandemic, and we were able to come together. That was the only time in my living memory that all presidents were on TV washing their hands and, giving messages. But otherwise, it's PEPFAR is having its own program. WHO has its own program. And we keep on reinventing the wheel. It's the same thing over and over again. Why do we not have a synergized program that links HIV with cervical cancer elimination? They are so interrelated. The patients are, quite similar, and the tools that we need, the curative tools, are similar. So we can piggyback on these existing facilities. But when the leaders stay in the big summits and meetings and they have all these decisions, they're not thinking the AU is doing this and the ECOWAS is doing that, or the PAHO is doing that, and United Nations, everybody does his own. So there needs to be more synergy globally. And then at national levels, it will be easier. There are maybe 6 programs running on cervical cancer in my state. I'm not involved in all of them, but it's almost like if you talk about cervical cancer, people feel that ours is the only one, but it's not. JPIGO has the program running. And so that need to communicate better, I cannot overemphasize it. And to remove the bottlenecks as well. There's no reason why, if we already have one solution here, then let's extend it. I hate to sound very repetitive, but it's a leadership issue. Those kind of things. I'm sitting close to a leader, but I still have to deal with the problems of there are 6 parallel programs running and we don't know anything about them, or we're not able to synergize them. So it's a leadership problem. Somebody in the Ministry of Health, somebody at the Federal Ministry of Health level in this assembly where the MOUs are being signed, where the ethical permission for this is being given, has to take responsibility. I think this is where the issue of having a very strong National Cancer Institute comes in. And then you can domicile these kind of decisions with them. It's strange that for a country as large as Nigeria, we're only just starting up our National Cancer Institute, but I know that other countries have them and they've done reasonably well in this, but the problem still exists. So better communication, having centralized policies, and letting people talk to each other better.
Tamika, I wonder if I could shift the discussion a little bit down to the ground roots level. Because when we're talking about destigmatization, I have a question for the other panelists. One of our goals in the campaign, again, is to talk about HPV, get it out there for all the reasons that were mentioned. But I often wonder whether we're not concentrating enough on educating the men, not necessarily because they are at risk for HPV-related disease themselves, which they are, anal cancer, penile cancer, head and neck cancer, but they are also obviously playing a key role in the healthcare of the women in their lives. And I sometimes wonder if we don't encourage men enough with education to be stronger allies. We certainly don't want anybody to be getting in the way of good healthcare for women. And I wonder if there isn't some value in making clear how common the virus is and how important it is that the men work with the women that they love to make sure that they are getting the care that they need. This is, I know, a touchy cultural issue in some places. So I'm wondering if any of our panelists have any comments on that.
Yes, it is a sensitive in our society about HPV, HIV, and the involvement is still very less. To work in the community level, national level, local level, everyone should unite together. As Zainab said, like the health system should be fully involved. Every individual level, sector level, it gets involved, and the community will be receiving that service if it's nationally recognized, and if nationally it comes to a priority list. That is my belief. Thank you.
Okay, and if I may say something from here in Kenya, it's we still have a long way to go, and we still need to reach out more to talk to our men, because here it's I don't know how to call it, but I can say it's in a difficult situation. Out of like the most of the men believe that they are the women because of lack of awareness or lack of information or lack of education. Men are believing that they are getting cervical cancer from women, and women here are believing that they are getting cervical cancer from men. So it is a bit tricky, and some of the doctors, when they go on national television, they say that women get cervical cancer because they had multiple men in their lives. So that is bringing a bit challenge to reach more information to our men, and men believe that they are only women who has this HPV virus in them. And out of 100, only 10% of men, or maybe less than 10% of women who are having cervical cancer, they are still in their marriage. When the woman gets cervical cancer, or maybe she has an issue on gynecological cancer, the first thing is their men just took off, and the marriage is like over. Like me personally, it happens. So it is good thing, like I support Her Excellency, the way she said we need to include everyone from the national level, from the Ministry of Health, and we need to say the way it is. This is HPV, and HPV is giving us cancer, is taking out our women, it's affecting our girls, it is affecting everybody in the society. It's like the pandemic, which is the pandemic that is not going away unless we talk about it and we address it. It's going to affect us.
And we may have touched on this. We're coming to the last few minutes of this, but I want to go around to the panel, and really, if there was, one thing you would prioritize to improve access to screening, what would that one thing be? And if if the money wasn't an object, if you had all the things, what would that one thing be? Dr. Shataverdi, I'm going to start with you.
Sure, I'll restrict my response to HPV-associated head and neck cancers, and I think the one thing we need is to gain the is to gather the scientific evidence for the efficacy of screening, and to the extent that we're able to empirically show the benefits of screening, that would go a long way in terms of making inroads into early detection of head and neck cancers. Because we have the tools on hand, but what we need to show is that putting those tools to work is very efficacious and it's cost effective. That is the one thing I would say is the need of the hour for HPV-associated head and neck cancer screening.
Thank you. Lillian.
Okay.
You're muted.
I would say that for all the doctors, the GYNs, to have HPV on their radars and not dismiss someone in the case of anal cancer, when a woman comes in and has symptoms and the doctor says, oh, it's just a hemorrhoid. I would say to get it on your radar that these cancers, although rare, they're on the rise. And I'm one of the front lines where I speak to patients every day, and it's really the same story. Just spoke to someone last night about this, and I would say to start talking about it, get it out there. You know, from the pediatricians way up, you know, to the gynecologist, to get on the same page and get it out there and start talking about it.
Thank you. Joel?
Well, unfortunately, there are two things I need to mention very quickly. One is I completely agree with the other comments about the need for political will. Nothing is going to happen unless that's in place. But the second part of my answer is we need to do a better job to not only educate the politicians, but demand the kinds of things that we know will save lives. And one way to start there, it's not the only answer, but we create demand by activities such as this campaign and other campaigns that make people aware of HPV, that we're all at risk, and that we all care for somebody who's at risk for these problems. And so we need to make sure that they are demanding from the political class the resources needed to save lives.
Thank you. And Dr. Colson?
Yeah, as Lillian said, the gynecologists and the doctors, I think they play a big role, because with my experience, I've been working with key population and with remote women. I have noticed that they feel more convinced when actually a doctor directly goes to their doorsteps and talks to them, speaks about it, and then a trust is built. I think a doctor can play a big role here, speaking to the people, directly going to the remote areas where no one is going. A female doctor plays a big role, whether it's key population, whether it's HIV, whether it's sex workers. They look high up to a doctor, and every sweet words of a doctor really carries a value in their life. As Lillian said, the doctor should consider it as a normal thing and provide that, encourage the people, please talk about it, come to me, speak to me. This is very important. A doctor can play a big role here. Thank you.
Thank you. And I hate to do this 1 minute split between Her Excellency and Millicent for their final thing that they would prioritize. Your Excellency.
Well, I think that it's very, we could say wishful thinking not to talk about funding, but you ruled that out, Tamika, so that's fine. I would like a world where we have more healthcare workers in Africa. I'd like to see less pool of our healthcare workforce by the high-income countries. I'd like a world where we have better leadership, where our healthcare doctors and the professionals are also dabbling in politics so that they can make these informed decisions better and stop being critical of them. And I think that if we are able to merge the two worlds together, then we can see so many things happening. I come from the largest country in Africa, the whole of Africa. Nigeria is the largest country with a population of over 230 million people. But HPV vaccine is not routinely available to girls or boys. So that would be my one wish for this year. I hope that I will see it this year. But my immediate wish for 2023 is to see HPV vaccine on the routine immunization being given to Nigerian girls.
Thank you so much. Millicent.
Wow. One thing I would wish to be done here in my country is like, we were told the Minister of Health is telling us in Kenya more than 9 women dies every day. Those are the women that we lose due to cervical cancer. And those are the women who are able to do the biopsy, which is very expensive. And I know if I do my own research and find out those women who have just died with cervical cancer and they did not do the biopsy, there are many. So we need to work on survivorship. As we say, more than 9 women dies of cervical cancer. We also need to remember how many women who survive to cervical cancer, so that we can bring it in a bigger picture. And when we say we bring that information outside there, I believe it will change another women who have gone for the screening, who are fearing, who have a lot of questions to do the screening. They will go and do the HPV testing so that they can not get where we are today. Thank you.
Thank you. I mean, we could go on and on and on. There's so much to talk about. There's so much that within this topic brings me joy, knowing that the future ahead. But there are a lot of pain points, knowing that while we're still doing this work and waiting, that people will ultimately succumb to HPV-related cancers. And so we all have the opportunity to help move the needle with that. And we didn't get a chance to talk about how people live beyond a cancer diagnosis and why prevention is so very important. Because I think you see us patients and you think, well, they've survived it and they've made it beyond their cancer. But I think I can speak for the patient advocates here and let you know that we all live with secondary issues that are not easy. A lot of us, we're happy to be alive and we move forward. For Millicent and Lillian and I, we've dedicated our lives to using our stories and the nonprofit organizations that we founded to move this work forward. For me, when I found out that there was a test to detect HPV for cervical cancer, and then years later there was a vaccine, that is what made me want to share my story. If you are a patient and you're watching this and you're on the fence about sharing your story, join us. We need you. For those of you who have been doing this work for a very long time, we thank you. Today, we're kicking off International HPV Awareness Day, and there's a wonderful campaign that is going on with the International Papillomavirus Society. I know a lot of us sit behind computers and we do a lot of work. We see patients, we research, but social media and being involved in these campaigns add value. Why? Because they decrease stigma. They also increase funding. They also make our political leaders pay attention and know that HPV is something that they should care about. So I ask you to join this campaign that will be kicking off and we're going through, and to share the content, to ask your followers to also share the content, because the work that we are all collectively doing needs to be amplified. It needs to be visible. And so don't let it sit here and sit just with the work that you're doing, which is incredible, but share these campaigns so that we can make noise on social media and have people who may not have shared or may not have known about what issues that we need to help amplify this. We need everyone involved, because unlike so many other things, we have the tools. We can do something about HPV-related cancers. On behalf of IPVS and everyone here on this panel, I thank you, and thank you for joining us. We appreciate you and all the work that you are doing. Thank you so very much.
Thank you.